Sherry, thank you for the kind introduction. It's a pleasure to be here today, and excuse my Marco Rubio moment. I'm a political junkie. So I am going to speak about pharmacists in the ED, and I think people have already asked this, but I didn't see the show of hands earlier. How many folks are physicians in the audience? Okay, and how many are nurses? And how many have a significant part of their day that's involved in emergency department administration? Okay, thanks. So I have no conflicts of interest. I do some outside work. I'm on the Scientific Advisory Board for Emergency Medicine for United Healthcare. I also have current grant funding from the Agency for Healthcare Research and Quality and the Blue Cross Blue Shield Foundation of Massachusetts. This doesn't have to do with pharmacists in the emergency department. So today we're going to talk about the roles that a pharmacist can play in your emergency department. And it looked like the majority of folks have pharmacists, so many of these may already be there, but maybe we can think about a couple new ones. We'll review a little bit of the evidence to support pharmacists in the emergency department, and we'll discuss some strategies for implementing a pharmacist program if you don't already have one. So in the last year, in your emergency department, has there been a serious safety event related to medications? And I don't mean, something that was caught a near miss, but something that went to risk management, a patient was hurt, or something like that. Who's had that happen in their emergency department? And just to get a little more granular on the question that Sherry asked, who has 24/7 dedicated pharmacist service in their emergency department? Raise your hand high. So a couple people, probably in academic centers or very large centers. Who has part-time pharmacists? Okay, about half. Who does not have a pharmacist, but it's coming? The program's been budgeted, okay? And who does not have a pharmacist in the ED? So maybe a little more than half don't have a pharmacist in the ED. Every medication that is prescribed in the hospital to a patient, from Tylenol to their antihypertensive medication, gets reviewed by a pharmacist in many or most hospitals. And yet our environment is incredibly more complex, difficult, and dangerous. And so the question isn't, or shouldn't be, why do we need a pharmacist in the ED, but why are the pharmacists in the hospital spending time checking the blood pressure medications as opposed to our high-risk medications? So if you think about the emergency department environment, all the things it's high volume. We have an incredible diversity of patients. The patient history is often not readily available. We have constant interruptions in our workflow that can lead to errors in the process of prescribing. And medication ordering, dispensing, and administering are all at the point of care, as opposed to being broken up where there can be safety checks. Our environment is fast-paced. We frequently give verbal orders even though we're not allowed to, and we don't routinely have pharmacist review. So academic pharmacists have done safety studies, and they've broken down the whole process of prescribing, and this is sort of the model. And if you think about it, the model includes prescribing, transcribing, dispensing, administering, and monitoring. Those are all of the safety checks that are not available routinely in the emergency department because of our standard workflow. And so we need to think about ways that we can build back in some of these safety checks to avoid adverse events. There have been, at this point, a whole series of studies looking at the prevalence of adverse drug events in the emergency departments. It's a pretty popular study to do, and it's relatively straightforward to do because there's a well-validated system for judging different events. That doesn't mean that the terminology that's used in these studies necessarily comports to what you would think of as a clinician in terms of what's serious and not. But there have been a number of these, and they're pretty reproducible. About 3.6% of ED patients receive an inappropriate medication. About 5% receive an inappropriate discharge prescription. Established safety checks are often not available in the ED, and these are pharmacist review for ED medications, oversight of verbal orders, preparation of medications, and involvement in the clinical decision-making. There are particular challenges with pediatric patients. Weight-based dosing applies, and there's a different set of medications that we may only use in children. So there have been studies of pediatric adverse drug events, ADEs or adverse drug events, and it's estimated that 100 prescribing errors and 39 administration errors occur per 1,000 pediatric visits. 22% of acetaminophen doses were ordered incorrectly. I would be in trouble if at a conference put on by Dr. Bucata, I didn't mention that when they reviewed this study in the EM abstracts, a lot of that was maybe dosing at 15 or 20 mg per kg, not a dose that is necessarily toxic. But there are multiple studies that show that we are more likely to commit these errors in kids. So what can an emergency pharmacist, which I'm going to abbreviate as EPH, do in the emergency department? It's not just reviewing your orders. That's the key takeaway point. To have a successful program, they have to be a partner in all aspects of the ED. So they can have clinical consultation duties. They can give dose recommendations, and this is how I frequently use them when I am using a medication that I have not used frequently. Rather than going online, our ED pharmacist has a cell phone, and I can just call them up and say, I have this patient, and they're allergic to these 3 antibiotics that I'd usually use. Can you check my medication dose on this? Therapeutic substitution information. So either due to allergies, shortages, or interactions, they can be very helpful and save a lot of the time that you need to be using to see patients. They can do order screening. Now, if you have a very robust program, it's possible for them to screen a large number of orders, but in most of our EDs, you're going to have to do triage. And so what should they screen? It's helpful for them to look at allergies and drug interactions. It's helpful to look at pediatric orders, particularly in the smaller kids. And you can help have them look at high-cost medications. Many of the things that hospitals may put on restricted lists, and at 9 at night, you would have to make a call to someone else. If you have an ED pharmacist program, you can build them in to that decision tree. They can be involved in the preparation of medications, high-risk medications. So in our emergency department, every time we give TPA for stroke, an ED pharmacist is involved in that process. And there's a smaller number of ED pharmacists than there are nurses, and since it's a relatively rare event, it helps ensure standardization of that process. You can also have them respond to the high-risk events, so traumas, resuscitations, critical patients, when you're going to be giving pressors, other things where having their input is going to be more high yield. Additionally, it's important that they not just be someone sitting in the background checking medications. For them to be successful, they need to be dedicated to the emergency department. You want a pharmacist who's a people person, who's willing to come out, talk to nurses, talk to doctors in the flow of work, and also be involved in your quality improvement programs, be involved in your faculty meetings to present new information. They should be physically located in the ED. You may have a great IS system and they can sit somewhere else and check things, but if they're not physically in the ED, folks won't use them, they won't trust them. They need to be provided with a computer and online resources. If you have electronic health records, it's obviously easier for them to check the medication administration. It's great for them to attend rounds. If you have change of shift rounds, they will often ask questions and if you build that into your culture, that you may not normally discuss. You want them to be easily accessible and visible to all staff, and you want them to walk through the emergency department and actually talk to the nurses and be visible, because that's the way they'll get used. If they're sitting in the corner reviewing medications, you won't think to go to them. They should be available by pager and phone. So what can they do as an educator? They can educate on medication-specific, on patient-specific education. So in RED, we have them do the teaching for patients who are getting started on low molecular weight heparins. The DVT patients we're going to send home and give scripts. We have them do teaching on that. They can do some teaching with new diabetics or diabetics who need more control. They can do discharge counseling for patients who are on difficult or new medications. They can do education with nursing, new medications and high-risk medications. Drug warnings, should be involved in mock codes if you're having mock codes, which are great. And they can also work with nursing on safe medication delivery. What can they do with your providers, physicians, PAs? Evidence-based reviews of specific topics. There is a big part of our practice that is obviously prescribing, and so much of it is based on either what we were taught in residency, what we have picked up as habits, and there is so much evidence that's changing. As there's increased focus on things like antibiotic stewardship and cost containment, there's a real role to try to review these policies and bring the best evidence, and that's something that you may not have time to do, but if you can have your pharmacist put those together, it's great for your education. I'm sorry this didn't come across particularly well. This is one of the studies that looked at the cost-saving effects of a pharmacist. And so they followed a pharmacist around for 4 months in the ED. This is a study by Latta et al. And they looked at different types of interventions. They looked at drug-drug or drug-disease interactions. They had 334 of those. They looked at therapeutic recommendations. Use this antibiotic, not these two. They looked at adverse drug events prevented, a much smaller number. And they looked at medication errors prevented. And they estimated costs per avoidance. Some of these are easier to estimate, like the cost of a medication is pretty easy to estimate. The cost of an adverse event is a little more vague. But they found that in this busy community ED, that over a 4-month period, they had a cost avoidance of around $1 million. The study that I was involved in at the Brigham was a 4-center study looking at ED pharmacists, and we had pharmacy students who were present during their residency, and they were trailing around certified pharmacists, and they just watched the work that pharmacists do, and they made notes of the different interventions that occurred. And this happened at 4 academic medical centers throughout the country. There were 226 observation sessions over almost 800 hours, and pharmacists reviewed over 17,000 medications. In this process, we identified 500 recovered medication errors, so error about to be made and it was recovered before it hit the patient, or about 8 per 100 patients, and 2.9 per 100 medications. Most of the recovered medication errors were intercepted potential adverse drug events. So a provider ordered, a physician PA ordered a medication, and before it was administered, the pharmacist reviewed it and either changed the dose, changed the medication. A small number were ultimately got to the patient, the ameliorated adverse drug events and mitigated adverse drug events. And these ranged in severity from things that like giving the wrong patient something they would have an allergy to, which could be potentially life-threatening, to giving a patient an underdose of antibiotics, which is serious but not going to cause them immediate harm. And so this study and a number of subsequent studies have shown that in the emergency department, pharmacists can prevent a fair number of errors. So how do you do this if you haven't implemented a program before? The main question I think people are going to think about is what's the cost? And to the administrative folks, I think the important thing is really framing this not as an ED cost, but as a pharmacist cost for the hospital. We're part of the hospital, we're the most high-risk area for medication administration, and you really need to work with the pharmacist, pharmacy team to make this a pharmacy request and not come out of the ED budget. So when thinking about your needs, you need to think about what emergency department type you have, what your volume is, and the patient demographics. And then you have to come up with a financing plan. And the immediate return on investment is often not going to be felt because these are prevented adverse events. But when you build the financial model, you need to think about things like cost containment of expensive medications, because that's something that you can really show a return on investment. You have to think about recruitment. There's a national pharmacist shortage, as Sherry mentioned. And you also want to think about staff resistance. In cultures in emergency departments, we're quite used to doing things on our own. And you may have to, at the beginning, really point out to people that the pharmacist is not going to be interfering with the work that we do, but actually is going to be improving the safety. So the way to demonstrate the financial return on investment is to identify specific safety cases. And if you go back over the last couple of years and identify medication cases that have gone to risk management, they've had to be reviewed, and if you can identify that a pharmacist could have prevented these, that's a powerful financial argument. Additionally, the things that can show a direct return on investment include recommending lower cost medications such as antibiotics or reducing the actual number of medications given. If a full-time position is not an option, then you should think about what can you do to flex someone who's already there into the ED, and think about the busy hours and the tasks that are highest risk. So the pediatric patients, the code patients, and just physically locating that pharmacist in the ED to do the work that they may be doing remotely, checking medications on the floor, can give you more coverage. Because much of what pharmacists are doing now with electronic medical systems is sitting somewhere reviewing those orders on a computer. If you can get them to sit in the ED and do that, they're immediately available. So this is a picture from the University of Rochester. Terry Fairbanks, who was at University of Rochester, did a lot of this groundbreaking work. He's now at George Washington, but this is their pharmacist, and their office is in the trauma bay. Our pharmacist office is one of the computer workstations in our observation unit, and that's a good place for us to put them because those patients are there for longer, so we have them actively review all of the patient's medications in the observation of patients who go through observation. We don't have them review every medication on every ED patient. We have them review high-risk meds, code situations, and then when we have a clinical consultation. So what about recruitment? There's a shortage of pharmacists. So you want to think about getting somebody, the right person, not just getting somebody. You want somebody who's got a residency in pharmacy. They actually do those. You want to get someone who has acute care training. Having a pharmacist who's worked in the community come straight into the ED is likely going to be a big culture shock. The work pace and the interaction clinically is not going to necessarily happen immediately. Having experience in either critical care or acute care is going to be very helpful. And you really want a people person because in our environment, if the pharmacist doesn't reach out to people and is afraid to go talk to the nurses, is afraid to go talk to the physicians, then the benefits of the program are not going to be there. So a good thing to do is have any potential candidate spend a couple days or at least part of a day following staff around and really get frontline staff's feedback. And if they say this isn't a people person, it's the wrong person for your ED. So in summary, emergency pharmacists can improve medication administration in the ED. They can add safety at a number of the checkpoints that we already miss in emergency medicine. It's important because we have limited resources to focus the emergency pharmacist on high-risk areas. So think about pediatrics, think about code conditions, think about high-risk meds, anticoagulants, things like TPA. And then think about innovative uses for an ED pharmacist. If this really is going to have an effect, you want to get them to do things like quality measure real-time review. So we have our pharmacists look at our medications prescribed for pneumonia, and they know the pneumonia rules better than anybody except for the quality folks in our ED. And so when an attending has a question that's not, there's an allergy or they were on this medication, they want to make sure they meet the metrics, they can go to our pharmacists. And then especially as we move towards more patient engagement, engaging your pharmacist in critical teaching. So if the CHF patient who is not taking their medications because of some side effect, someone who you're going to start an outpatient pathway for DVT or for other things, but a key part of that is starting medications. All of those things are roles that a pharmacist can definitely assist with. So there are great resources on the web. University of Rochester, which did a lot of this pioneering work, has a website called emergencypharmacist.org. Additionally, a number of the things that they've published and that other folks have put out are available on the Agency for Healthcare Research and Quality's page. Additionally, the American Society for Health System Pharmacists has a whole part of their website devoted to building up an emergency pharmacy program. So if this is something that you're thinking about, I would highly recommend looking at one of those resources. So happy to take any questions. Right there.
The biggest barrier really, I think, has been the ROI discussion. And you touched on a couple of studies, but the studies really soft benefits. And to my knowledge,
So the question was, the pressing question at most places that don't have this program is what's the return on investment? And most of the studies have been done in academic centers, tend to be higher volume, maybe more complex patients. Where is the ROI, and is there sort of an inflection point or someplace that you can make that case, especially because a lot of the cost studies have been sort of softer estimates of what the cost of a avoided event would be. And I think that is a weakness in what's been published around the costs, but I think you can build a compelling case for this. Every ED cannot afford to have emergency pharmacists available 24/7. But a busy ED can make the case to have somebody there during peak hours. And I think the things to talk about are to identify those medication errors. And I do case review for our ED. I also advise our risk management group for 7 EDs, 2 of which are academic, 5 are non-academic. And there are medication errors that make it to the risk management folks from all of these EDs. So they're there from your ED. And if you can identify how a pharmacist would have helped prevent that, I think that's one case. A second is that in many places, the emergency department has been relatively exempt from prior authorization, ID approval, other things for expensive medications. But if you if you have your pharmacy team or your hospital informatics team look at the high-cost medications given in the ED, and you want to make a case that you're going to reduce those, you could have your pharmacist involved in a quality improvement project. And so we had a project looking at vancomycin, which wonderful drug, but somehow it became a standard for all patients who had pneumonia at one point. And we sort of looked at that, and the pharmacist was instrumental in getting us to reduce the use of that. And then the third piece is, I think, making the case that we're the high-risk area is worth doing.
Any other questions?
One of the most terrifying moments in the electronic world for our hospitalists is doing the med reconciliation. Have you had any experience with that? And that's one of the few benefits we were able to find, is because I'm at one of these super jumbo centers with transplant patients, and they're going upstairs and they missed all their anti-rejection meds for 2 days. And so that's kind of how we're trying to make our pitch, is to get the folks back on their right medicines.
So I think I hear 2 questions in that, sort of what can pharmacists do about med rec, and then can they solve the emergency department's med rec problem? In our ED, we have the pharmacist review, do a full reconciliation on the medications on patients who go to observation or patients who are admitted, because those we think are the highest risk, like you gave the example of the transplant patient. And the OBS patients were often giving their outpatient meds and new medications at the same time. We don't have them do med rec on our average patients who we're treating and releasing, and that's a resource issue. Even though we have a 24/7 ED pharmacist, we don't want them to spend their time on that, and so we have other clinicians doing what's required of med rec. And sort of how that shakes out at each ED will depend on your staffing and costs, I think.
Do these need to be pharmacists, or can they be pharm techs and stuff like that? Do those exist?
I think for the ED environment, at a first level, if you were going to have one person, you really would want a pharmacist, because they need to make it worthwhile, you need someone who can do a number of these different roles. And there are pharm techs, and if you had a big program, you could probably delegate some roles to them. But if you want someone who's going to be able to independently review orders, do teaching to clinicians, and sort of stand there in a busy ED when there's a code or when someone's getting TPA for a stroke, you need someone with that advanced training.
Any other?
There's one in the back.
Hey, Jay. Steve Davidson, Maimonides, Brooklyn. Going to step on your presentation just a little bit. We have a big pharmacy residency, and for the last 5 years have had an ED pharmacy fellowship. And I'm just wondering if anybody else in the room at their hospital has a pharmacy residency. Well, I know you do. If you can connect to a pharmacy school for this, it's an incredible way of getting really engaged people. We do not have 24/7 coverage out of this program, but we have 18 to 24-hour a day coverage, probably half of that coverage coming from the ED pharmacy fellows. It's spectacular. They are just wonderful, and all the value Jay speaks to. So I just thought I'd share what
That's
we're
a great
doing
point.
in Brooklyn.
It's a great point. I didn't include it because I didn't necessarily think that most people, but it's a really good point. If you do have a pharmacy school locally, and it's something that the pharmacy residents and students really enjoy, because it's the same reason anyone likes to be in the ED. You know, it's where the action is.
Gil Shlomovitz from Baylor, Houston. We have a pharmacist at Ben Taub. It's a clinical department with a fellowship. I was wondering if you guys do a prospective or retroactive review in the EC, i.e. do nurses actually execute orders before the pharmacist got to them? At least in my shop, pharmacist has to review on their screen electronically everything that goes on the MAR. That includes IV boluses and things like that. Were you able to prioritize their work to actually look at high-cost/high-risk medications?
So I think any ED's ability to do this will largely have to do with their electronic systems. So we're in the process of transitioning from a bunch of old, at the time innovative but non-communicating systems to Epic in the next couple of years. So right now we can't have them do prior review on all medications. So what we've done is we've set up page alerts to the pharmacists when high-risk medications are ordered, and so they know to review those, and they review them before the nurse can get to them, and that's sort of how we've. But a lot of it has to do with what your IS systems are.
All right, thank you, Jay. Let's have any other questions maybe at the back of the room so you can get your 15-minute break.